Hi, I'm Joel White. I'm the president of the Council for Affordable Health Coverage, or CHC. CHC is a broad-based advocacy alliance with a singular focus, bringing down the cost of healthcare so that all Americans have access to affordable coverage. And each year we host a Price of Good Health Summit where we aim to unearth the challenges and develop the solutions that will help promote affordability. This year is our fourth annual summit, which we're classifying as the pandemic edition. And we're doing things a little bit differently. We're splitting up the historically day-long conference into three parts. Look, I know Zoom fatigue is a real thing, and we want to be cognizant of people's attention span. So we're trying to break it up and make things a little bit easier. I also want to thank this year's sponsors, the Blue Cross Blue Shield Association and Pharma, for their support of this effort. Today's session is our opening, and we're focusing on costs, how the pandemic impacted the healthcare cost curve, what other types of costs, both social and economic, were impacted, and the lessons learned from the various healthcare sectors, the payers, providers, manufacturers, employers, and hospitals, and how they're dealing with healthcare costs and spending and prices. The director of the Congressional Budget Office, Philip Swagel, is going to be with us later. He'll give the keynote speech at 12:15, and you will have the opportunity to ask questions via the Q&A box. And then we'll follow up with the panel discussion, and that's going to feature leaders from IQVIA, the National Association of Manufacturers, Blue Cross Blue Shield Association, the Federation of American Hospitals, and Teladoc. And so I look forward to a productive discussion, but first off, I'd like to level set on a few key policies and trends and what we're seeing during the pandemic and where we might go from there. And so first of all, I think just a broad overview. We're going to spend $50 trillion on healthcare over the next 10 years. Most of that spending is on labor, hospitals, doctors, nurses, et cetera. But about 30% of that is waste. That is care that does very little for the patient or might even harm them. And that's a big chunk of change, about $1 trillion. The second point is that costs have consistently outpaced wage growth and inflation and economic growth. And that means health costs rising more, faster than wages creates an affordability gap and makes coverage much less affordable and more difficult to purchase. Thirdly, I think we all probably know this, but we have the highest healthcare spending per capita in the world, but we have falling life expectancy, certainly during the pandemic. We have high variation in quality, health markets are not transparent, and consumers wield very little power. And then what we saw during COVID really was fascinating. Health spending decreased. There was a lot less access to services and voluntary care. Perhaps for the first time in 60 years, that health spending went down. We saw an unprecedented increase in telehealth, and in addition, life expectancy decreased, but it decreased disproportionately among certain subpopulations. And so I wanted to go through some basic overviews and then kick it off with the CBO director. First of all, I think it's important where we get coverage. More than half of the population gets it through an employer. They have job-based coverage. But really, for the past decade, Congress and the administration and the public have been having a discussion and a fight, quite frankly, over that little sliver of the market, the individual market, or Obamacare. And we've ignored kind of where most people are and where most costs exist, and that's in the employer side of the equation. And secondly, if you think about the uninsured, it's about 30 million people out of 333 million people. So about 10% of the population. 20 million of those 30 million, though, have access to subsidized coverage, but they're not enrolled. The other 10 million, about half of the 10 million without subsidized coverage, about half of those people are undocumented folks here in the country and lack legal access to that coverage. About 2.3 million people in the Medicaid gap, or the states that didn't expand coverage. And then the remainder are kind of either high income, they're self-insuring, or they don't see the value in coverage or have other issues. And so we've done a really good job on the coverage side and expanding the folks with insurance and the folks without insurance, reducing that number, and spent a lot of time and effort on the policy side in Congress and administration, quite frankly. But if you think about where the healthcare dollar goes, the cost issues are really not being addressed in fundamental ways. And so, most of the healthcare dollar is spent on services, either hospitals or professional services, about 10% spent on prescription drugs. And that's true today, and CMS projects that will be true over the next 10 years. So a lot of consistent cost growth across these slices of the pie. But again, they're growing faster than wages and inflation. If you take a look, we've drawn the affordability gap here on a chart for you. It's really accelerating over time and creating a wider gap between the cost of health coverage and wage growth. There it is there. So since 2010, that trend has gone up by 92%, 4 times faster than the average wage and 5 times faster than inflation. And that's really unsustainable for a lot of our families. What we see in ESI and other markets is that more of those costs are being picked up through higher deductibles, higher out-of-pocket costs, and some of the premium being pushed back onto the consumer. So it's creating real challenges for families and individuals. But what I want to get into a little bit now, that's kind of the macro view, is what we really saw during COVID-19. And the Director Swagel is going to get into some of these things from the CBO perspective. But let's kind of dive into it, thinking about those categories. So the first impact of COVID was a lot of people lost work, right? They lost their jobs. And because most people get their health coverage through their job, they went somewhere. They either became uninsured, and this table kind of shows that, that big box, 30% uninsured. Some went into the ACA marketplaces, but most went to Medicaid. And we saw a lot of people lost their employer-sponsored coverage. And if you take a look at the small group market, what we've seen is access to coverage is really correlated to how many employees you have. And so what we've seen is the general trend over the past 10 years, and then we project it out over the next 10 years, is a real reduction in the small group market, where a lot of people work. About 33 million people work in these small businesses. And those are the businesses that got hit really hard with lockdowns and capacity limits, and lost a lot of businesses. Many of them went under, had to fire workers. And so, I think the takeaway from a coverage standpoint is that Congress stepped up. They provided COBRA subsidies. Like Medicaid, that should be a permanent fixture. So when we have an economic downturn, we don't have to wait for Congress to act. It's just there's a COBRA subsidy on the table available to people. And then secondly, on the small business side, if we're going to have a policy where we're going to lock down businesses and harm their economic potential, we ought to be providing a reformed small business tax credit to help them with provide the coverage that they're providing to their workers. And then finally, the other thing I wanted to mention on the coverage side is that we just started open enrollment for Obamacare exchanges. And we just released a report card on those exchanges. And you see the report card here. We graded on an A to F scale on 11 consumer measures of how well the exchanges do to present information so that people know that the plan that they're choosing will meet their needs. And you can see that there's a couple of A's, but mostly B's, C's, and D's, including healthcare.gov, which is kind of right in the middle of the pack. And some of these measures have improved over time, but the point here is that if we're going to accelerate access to ACA subsidies and more people are going to go through that market, we need better tools to help make informed decisions. And the other thing I would say is that there's a lot of money going into the Navigator program right now. Those folks are not licensed like agents and brokers are. And so I think we need to take an examination of the Navigator program to help people make the choices they need on the coverage side. So that's some of the coverage issues. Let's go on to costs. And I think what we saw again was this unprecedented change in 2020. This is the numbers for total spending 2020 to 2021. And again, what we saw was perhaps a real decline in healthcare spending. Home health was the only one that went up, not surprising. Most people didn't want to go to a skilled nursing facility. They didn't want to risk getting infected by COVID. And so more people were getting services in the home, but across the board reduction by industry type. But then when you think about what makes up costs, it's utilization and price and intensity of services. And what we saw on the price side was a different story. This next chart shows by industry sector what happened over the April 2019 to March 2021 period. And if you can spot the outlier here, it's prescription drugs growing at a negative rate of 2.3%. And I would just say that Congress has been focused on the prescription drug issue as part of the broader Build Back Better agenda, but I think that we're ignoring some of these other categories of where there could be significant price and cost restraint that would lead to better affordability. And the other thing I would say during COVID that we saw was that because of Operation Warp Speed and some of the other issues going on, a real explosion in innovation. And it'd be horrible if Congress enacted policies that kind of led to a pullback on innovation in that space. And then on telehealth, this is kind of like the golden story of the pandemic, right? We saw an incredible spike, a 3,500% increase in use of telehealth based on claims volume, and then a kind of leveling off back down about 10% of all claims being delivered via telehealth. Makes sense. Again, we don't want to go into the physician office to potentially get infected if we can see the doctor via technology that we've all become comfortable with. But what we're trying to show on this chart from Fair Health is that not all telehealth is the same. And what we've seen is that for specific disease states and conditions, really persistent use and substitution to telehealth away from in-person care. And this is nowhere more prevalent than in the mental health space, where we're seeing upwards of 60% of the claims still at using remote tools to access that care. You can't use telehealth for chemotherapy administration, for example, but it seems to work really well in mental health conditions, and that's substituting out for some of those more expensive settings. And I know the CBO director is going to get into that in a little bit. And the final point I'd like to make is that the real tragedy, obviously, from the pandemic was a 1.87 reduction in the number of years of life expectancy. But I would point to that bottom set of numbers where we saw an even greater reduction for Hispanics and Blacks compared to whites. And we also saw a greater reduction in the US than we did in other peer developed countries. And so we've got lots of work to do. If we don't address some of those challenges, I think it leads to really bad outcomes like death. So knowing all of this, kind of where do we go? I think I could sum it up where CHC is. We're going to hear different perspectives on the panel, and I'm looking forward to that. We want an automatic COBRA subsidy during economic downturns to help people where they're at. Secondly, we need better tools to promote choices. Third, we want to support those small businesses that got disproportionately impacted by COVID with a reformed healthcare tax credit. Fourth, we want to expand account-based plans as options. And then lowering costs, expanding telehealth, certainly, addressing low-value care, $1 trillion problem, lowering medical costs without harming innovation, and really addressing those disparities in healthcare that the pandemic laid bare. So appreciate you all giving me the time to kind of go through that level set. Hopefully that provides some context, or at least how we're thinking about these issues. And for now, though, I'd like to turn it over to the CBO director. Philip Swagel is the 10th director of the Congressional Budget Office. Previously, he was a professor at the University of Maryland School of Public Policy. He was a visiting scholar at AEI and the Milken Institute. And prior to that, he was the Assistant Secretary for Economic Policy at the Treasury Department and did a stint at the White House's Council of Economic Advisors as Chief of Staff and Senior Economist. Obviously very busy right now with what Congress is doing with the Build Back Better agenda and legislation. So Dr. Swagel, we really appreciate you taking the time today and look forward to your presentation.
Great, thank you. Thanks, Joel. Thanks so much. And thanks to the council for inviting me to talk. So I'm going to talk about our work in the area of health policy over the past 20 months, really, as we've supported the Congress in responding to the pandemic. As Joel just said, we're in the midst of a lot of work on a variety of health-related issues with the current legislation. I'll stop ahead of 12:45. We can have some questions and discussion. I look forward to that. Obviously, I'm not going to talk directly about the work that we're doing now, but hopefully a discussion of the experience during the pandemic is helpful for understanding our process and understanding instances what that means for current legislation. Let me just start with just a few words about CBO and that, look, the agency is nonpartisan and is mission driven. The nonpartisan means we take no position on legislation, and this is the way Alice Rivlin set it up 45 years ago, and it's just deeply embedded in the agency's DNA that Congress gets our analysis but not our opinion. So that's just something to really to know deep down about the agency. And in some sense, are saying that something costs money doesn't say whether it's worth it or not worth it, and that's intrinsically up to policymakers and not up to us. Now, of course, health costs enter the budget in many ways, and so understanding the impacts of the pandemic on healthcare and the effects of the policy response is central to our mission, and that's supporting the Congress with our budget and economic analysis. So please go ahead and flip to slide 1. Great. Okay, thanks so much. So here you can see some of the major COVID-related legislation. I'm going to just very quickly go through, go through some of it. You actually go ahead and flip to. I'm sorry, flip backwards. I think you skipped a slide there. Good. Good. Okay. Yeah, this is it. Perfect. So this is the first 4 pieces of legislation. These are the ones enacted toward the start of the pandemic. And then go ahead and flip one page. Great. Okay. Thanks so much. And then these are the additional policies. These were enacted in December, along with the appropriations that fund the federal government, federal agencies, and other activities. And then the American Rescue Plan Act in March of this year. So again, this is I'm showing you information that's on the CBO website. I'm not going to go through it all, but go ahead and flip to the next slide, please. Excellent. And I should also just say, along with the overview, that on our website, we have published 2 side-by-side tables that summarize the provisions in all 6 of the pieces of legislation that were enacted in response to the pandemic. And these come to, it's a total of $3.3 trillion, nearly $3.3 trillion. That was in the 5 bills in 2020, and then nearly $1.9 trillion in the American Rescue Plan Act that was enacted in March. And then obviously there's more in the legislation being considered in front of the Congress today. So here's the overview. I'm going to focus on the health analysis aspects. I'm not going to talk about the macroeconomy. So eventually I'm going to skip over some non-health related slides. So go ahead and please flip to the next slide. Great. Yeah, thanks so much. Obviously healthcare naturally featured prominently in the fiscal response to the pandemic, given the nature of the pandemic. That's not a surprise. And then also just given the many ways in which healthcare and health policy feeds into the federal budget. Again, it's not a surprise. So go ahead and flip to the next page. Oh, I'm sorry, flip back one. I apologize. Perfect. Okay, very good. Okay. I should say just another note about CBO and the way we work is we work very closely with policymakers and especially with staff as legislation is developed. So we provide technical assistance on the language, on the costs, on implications of various policy choices being considered. And we did that with the legislation during the pandemic, and we're still doing that as we speak on the Build Back Better legislation, right? So this slide, stay on this slide, this gives you a look at the first COVID bill, which I know feels like a long time ago, and this provided some supplemental appropriations for the health-focused agencies, CDC, NIH, FDA, some funds for vaccine research. Now that's actually pretty straightforward in terms of our cost estimates, right? A certain amount of money, we project out the pace at which those dollars will get spent. We have experts covering each account in the federal budget with experience doing just that. It's relatively easy. It's not always easy in the sense that some of the appropriations over the course of the pandemic are just much larger than has been the case in the past, right? The activity is just getting much more funding than in the past. So having to figure out, well, what's the pace at which the money gets spent out? But that's, again, we have experts, we do that. The more difficult part is the line at the bottom, and that's on the telehealth services. And the challenge there is that, well, what did the provision do? It expanded coverage in Medicare for telehealth by temporarily waiving some restrictions, such as the requirement that patients go to designated telehealth centers. And it's, I mean, it sounds almost preposterous for us all sitting here today, right? If, you know, any of us get sick, we touch a few, you know, few places on our screen and get connected to, you know, a provider of some sort, and, you know, and get some healthcare services. But back then, back before the pandemic, you actually have to physically go to a telehealth center. And so these were in rural areas, you had to go to a telehealth center. And, you know, so it's hard to imagine back, you know, back then, and obviously it's something we're looking at today. So we had to figure out, well, what did that mean? And the other challenge is, well, so the first challenge is, well, okay, what would that do to usage, right? We waive this, people in Medicare can get healthcare more easily without having to go to a center. So you expect some usage, maybe there's some cost, you know, cost there. Perhaps there's some health benefits, and that would have some savings. Okay, so those are difficult questions on their own. The next part that was really a challenge was that, well, the waiver was for the duration of the public health emergency. So the public health emergency associated with the pandemic was declared on January 31st, 2020. So this is before the US economy shut down. But it meant that we had to figure out, well, how long would the public health emergency last? So then you know, the next, you know, the subsequent bill, the Families First Act, was the second COVID bill. That was March 18th of last year. So that had other provisions that depended on the duration of the public health emergency. There's a higher FMAP, right? So increased federal support for states through a higher Medicaid match rate, and federal contribution for children's health insurance, the CHIP. There's also a continuous coverage requirement by which Medicaid recipients would remain eligible for Medicaid for the duration of the emergency, rather than having to recertify annually, right? So these are again, the first and second COVID bills, not even the third one, the CARES Act was you know, much larger, but the first two had provisions that depend on the duration of the public health emergency. And again, this is at the beginning of the pandemic, you know, before the US economy shut down, and just as the US economy was shutting down. And these provisions were enormously consequential. So think about just the continuous coverage provision. And again, that's in the Families First Act, the second. So we have estimated that provision alone accounts for half of the increase in the number of people on Medicaid projected in 2021. And so it's Medicaid beneficiaries who we projected would stay insured rather than lose coverage, as might have happened otherwise, for administrative reasons, you know, not completing applications for recertification, not responding to state requests for income information, and so on, right? So it's an enormously consequential provision, and it depends on the duration of the public health emergency. So what do we do? And again, this is meant to give some insight into the way CBO works. Well, we had a group of analysts who essentially worked to generate the needed virus information. So we consulted widely with researchers in government and academia and industry around the world. And of course, we faced the same uncertainty as others did. So much back last February, which feels like a different era of some sort. So much was unclear about the transmissibility of the virus, the lethality. Would people get COVID more than once? How effective would a vaccine be, or even treatments? How long would it take to develop and distribute, and all that? We had to figure out projections of, you know, a variety of aspects of the virus. How many cases would there be? This is, you know, instances before the US is even doing effective testing. How many people would be hospitalized, since the US government picks up so much of hospital costs, both under, you know, pre-existing law and then with the COVID-related legislation. How many people would be in intensive care, since the cost is different, and so on. And again, we had to do this back in March of 2020. Now, Moderna, we all know now, I guess there's two books that have just come out that tell the story. Moderna delivered the first dose of this vaccine to NIH over here in Bethesda on February 24th of last year. But in February and March of last year, it was really hard to know, right? Would the vaccines be so spectacularly safe and effective, or you know, the time frame over which they'd be approved and deployed. Now, this virus group, I'm not going to go into every detail, but just want a couple highlights. So this would have been back in April of last year. we had a projection that there would be 500,000 deaths, so fatalities, through the end of 2021, the end of this year. So I have to admit, I was shocked. And of course, this is without, we didn't have variants, we didn't have the tragedy of, this is last 200,000 people who, who have died after the vaccines were shown to be effective and widely available. But 500,000 deaths, it turns out to be, nearly on target, again, leaving out the people who, were not vaccinated when they could have been. And we project the public health emergency to run through the first half of 2022. Now that's just our projection. Just to give you some insight into budget analysis, if the public health emergency continues past July, well, then we'll adjust the budget baseline, right? There'll be more costs. It's not up to us, we just track that. If there's legislation that ends the public health emergency early, well, that would score as a saving, right? There's lower FMAP and so on. I say one thing our projections did get is that our projections for future Medicare costs include a 50% probability of an annual COVID vaccine, the cost for Medicare associated with that. And again, this was made last summer is when we put that into the baseline. That actually looks to have been pretty astute. Go ahead and flip, please, to the next slide. Great, okay, thanks so much. And I'm just gonna talk a little bit about this analysis, which is some of our analysis of projections of health insurance coverage. And obviously, it's an important part of what we do at CBO is we, in modeling healthcare costs, we look at what happens with health insurance, since that affects the federal budget in a number of ways as well. So what is this? This just gives you a glimpse of one projection that we did. So our analysis of the impact of the pandemic on health insurance coverage. And so the left side of the slide, excuse me, the pie chart shows you the job loss, and then the right side, the stacked bar, shows you what's going on with health insurance, and it's only for a portion of this. So the left side of the pie chart is of the 14.3 million people who, on average, lost jobs. This is sort of converting to a full-time equivalent, did not have insurance coverage. So do not have an offer of insurance coverage. So then the right side shows people who had temporary job loss up in the top right slice of the pie, and then the bottom right is the permanent job loss. So of the roughly 14.3 million people with job loss, you can see that the loss of employment-based coverage is almost all among the people, of course, who had permanent job loss. And we calculate, this is the stacked bar, there's 1.3 million of them were projected to be uninsured. So what's happening there? Well, 1.1 million roughly still had employment-based coverage, either through COBRA, which was just discussed in the previous session, or enrolling in coverage through a spouse or a parent. And then there's other groups who had Medicaid, or non-group coverage, through the various programs of the Affordable Care Act, and then 1.3 million who we projected to be uninsured in 2020. So it's a huge number, right? 1.3 million people losing their health insurance as a result of the pandemic is a huge number, and that's incredibly meaningful to a huge number of people. There's inevitably, there has to be on the other hand, but it's a much smaller number than the number of people who lost their jobs. And this says something about what's happening in our society and in our economy and our healthcare system. Well, so the left hand of the pie chart, again, shows you that a huge number of people who lost jobs in the pandemic did not have an offer of employment-based insurance in the first place. So of course, this reflects the skewed nature of the pandemic affecting people in particular industries, particular occupations, people who did not have an offer of insurance in the first place. And then, of the people who did have an offer, some lost their jobs temporarily, and then others gained insurance coverage through other means. So there's a sense in which that's what's unusual. There's one unusual aspect of the pandemic is the effects of the pandemic on insurance coverage. That the disconnect, in a sense, between the number of jobs that were lost and the number of people who became uninsured. Again, illustrating two things, I'd say. One is the skewed nature of the pandemic, and then two is, well, the workings of our health insurance system and the workings of the social safety net. That, the 3.9 million people with permanent job loss, roughly 2.6 million, there's some rounding off here, gained coverage in other ways. And in some sense, that's the kind of analysis that we are set up to track. And then for the budget, of course, it matters as we analyze policies aimed at expanding insurance coverage. Great. Please go ahead and flip to the next slide. Excellent. Good. Thanks so much. I have this slide and then one more, and then I'll stop. So this just shows you the agenda from our annual meeting of our panel of health advisors. Had a session on the effects of the pandemic on spending, and then a session on telehealth, which again was just discussed, I know, in the previous session here. And there's a sense in which what's going on with telehealth is a microcosm of sorts as we think broadly about healthcare in the future, right? There's a sharp decline in utilization at the start of the pandemic, and we have to look ahead and say, will that utilization come back? And with telehealth, is that substitute for existing care or be additional care? We have to think about the health consequences of these changes. Does the expanded access to telehealth, does that improve health in a way that has a health insurance offset? I'm sorry, a medical offset, right? If expanded telehealth leads to better health outcomes, well, that might save money, such as in Part A and B of Medicare with hospital and doctor services. So that's the sort of analysis we have to do as we look ahead to try to figure out the impact of the pandemic and some of the legislative changes resulting from it. And then, of course, is the big picture question of, does this shock, the exogenous shock, as economists would put it, of lower healthcare utilization, what can we glean from that about ways to improve healthcare policy, up to policymakers or the healthcare system overall? And of course, we're doing lots of work on this, as was mentioned before, on prescription drugs as well. So both expansions of health insurance coverage, and then also on prescription drugs and many other aspects of healthcare. Go ahead and please skip ahead to slide 13, which should be the last slide. And so you can see I'm skipping over macro effects. Excellent. Okay, this is great. Okay, good. This is my last slide, and then I'll stop. Great to have a few minutes of questions. So I've talked about some of our health analysis in the pandemic. I know I've gone quickly and just touched on a few aspects. Hopefully this is helpful for thinking about our process. I've listed here some of the things that we're looking ahead at and thinking about the impact of the pandemic on the healthcare system and the budgetary effects of the healthcare system. And healthcare policy. Of course, we're thinking about what does it mean for productivity, for the overall economy, for labor force participation, which we know is down by several millions. Will those people come back? Sort of dividing between elderly or older workers who have left, parents who have left, for a variety of reasons. We're looking at the implications for mortality and fertility, which obviously has a big impact on the federal budget in lots of ways, including through Social Security and Medicare. The experience of the last financial crisis, or the last crisis, the financial crisis, back when I was at the Treasury, was that fertility fell in the financial crisis and then did not rebound. And again, not surprisingly, fertility declined in the pandemic. We're analyzing that now to think about what we expect to happen with fertility. I mentioned utilization and spending, and of course, all the macro impacts of the pandemic that are listed here. So what do we do now? I'll say a few words and close, and then hopefully we can have some time for a few questions. We're analyzing policies on all of this. We're analyzing policies on involving expansion of coverage in various ways, of course, through Medicaid, through Medicare, changes in Medicare, and then changes involving the exchanges established by the Affordable Care Act. We're continuing our work on policies involving drug prices, the impacts of those policies that would affect drug prices. What does that mean for families, for affordability? What does it mean for health? And then, of course, what does it mean for the fiscal outlook? And what does that mean for pharmaceutical innovation, which, of course, affects everything in the future, right? The health outcomes for families in the future and fiscal impacts in the future. And then, of course, looking ahead, we have other work that we are looking out into the future, trying to think about. I mentioned the impacts of telemedicine, the impacts of care that perhaps was delayed, and what does that mean for utilization and federal budget costs in the future. We're thinking ahead about other issues arising from the pandemic, opioids, mental health, other long-term implications. So all these things we're working on. Why don't I stop there and be happy to take questions on any of this or any other aspect of our work.
Great, thank you, Dr. Swagel. Excellent presentation. And obviously, there's a lot of different factors coming into play as a result of COVID and the pandemic, behavioral policy changes, and potential impact of past and current legislation. So a lot of complexity that you're dealing with. We just remind folks to submit your questions through the Q&A dialog box. And I do have one question that I'll ask you, but I'll go to the dialog box first. And this is by Randy Pate, who used to be over at CSIO. He says a recently published study looked at the inflationary impact of price-linked subsidies in the health insurance market, like the ACA premium tax credits that are linked to prices, and basically found that in Massachusetts, the price-linked subsidy inflated health insurance premiums by 6%. Is this something that CBO has taken a look at, and with the current proposal related to premium subsidy expansion? And if so, what do you think of the inflationary impact on premiums of a policy like that?
Okay, yeah, I know. Thank you so much, Randy. It's a great question, and it's something that comes up in a variety of contexts. And it goes back to the earlier CBO work on the ACA that focused so much on the mandate, and of course, subsequent experience shows that, as you wrote in the question, it's the subsidies. And so that's what's the key to thinking about the insurance effects, coverage effects of the ACA. So we do take that into account, is the automatic nature of the subsidies, and it comes in a variety of ways, including with the cost sharing reduction subsidies as well. So maybe I should just say a word on our analysis on the current proposal, right? And our past analysis of the American Rescue Plan Act, which had an initial expansion of this. We're looking at it on both sides, right? So what does it mean, as you say, for prices? What's the relationship back and forth between prices and subsidies? What does it mean for take up? As the subsidies are made larger and then up through the higher up into the income distribution. We're also thinking about what does it mean for the employer side, right? So the employer offer of health insurance. Now, obviously, with the temporary change in the subsidies, probably that's not going to have a big effect on employers. But as the subsidies become longer in duration, that might change. Both broader and longer. So the answer is yes. And all these pieces are complex and go together, but we do take that into account.
So, and again, put your questions into the Q&A box, but we've got more of a comment, and that's thanking you for doing more of the technical working papers on health and macro topics, really helping the community to understand your perspective, and the detail, and quite frankly, the analysis that goes with it is really helpful. One of the things I wanted to ask about related to some of those types of technical analysis is, CBO took a look at design options around the public option, and has taken a look at some of the issues surrounding provider consolidation. And I think that you mentioned during the pandemic, that was one of the factors that you're taking in as part of your virus task force. And we're seeing more M&A type activity. And I think that there's a large body of economic research that shows, you tend to have price increases in highly concentrated markets. So can you talk about some of those issues, especially in light of the technical analysis that CBO has done, and any kind of policy recommendations that CBO is considering or thinking about in terms of recommendations?
Okay, no, it's a great question. And so this one part of there's something there that's part of our job and something that's not part of our job. So the part of our job is to look ahead and try to understand where policymakers are going, so that we're ready with our analysis, right? We provide lots of support to policymakers, so that's the part of our job. And as an example of this, when surprise billing was a legislative issue last year, obviously those provisions got enacted in December of last year. There are a couple of analysts here at the agency who had figured out that was going to be an issue, and we were set up because they had figured this out. Before I became director in June of 2019, they had figured it out, and so I walked in and we were ready, and we had no view on what the right legislation is, but we were ready to support policymakers wherever they go. And so that's the second part, right? We're not going to put forward policy recommendations, but we'll help policymakers think about this. The way instances, I'm thinking a bit about the broad arc of policymaking over the course of the pandemic. Right at the beginning of the pandemic, when I put up the slides about the four pieces of legislation in 2020, and then the two, the one so far in 2021. So it's five in 2020 and one in 2021. The initial response, of course, was focused on speed and impact, supporting families, supporting the economy, supporting demand, and sort of getting money out quickly. And it's just natural. And there's less emphasis on negative incentive effects and targeting, and sort of just get money out the door, which of course made sense as policymakers face the pandemic. It seems like those considerations are shifting. There's much more focus today on supply side issues and incentives, targeting, deficit effects, and so on. And for healthcare, that naturally means that we need to start thinking about that in the future as well, about what does that mean for healthcare, efficiency, cost per person, things like that. And so, which all feeds back to to where we started. It's what is our work going to be in the future? Well, right now we're working on expansions of coverage. We're working on pharmaceuticals. We've done work on the public option. We did work before that on single payer. We have a really nice report that came out last year on considerations for a single payer system. And going forward, we know we need to keep working on that, but we're also we're going to come back to bending the cost curve. And you're not going to get CBO saying, here's what to do, but we know we need to be ready to support policymakers as they consider various options.
Well, let me ask you one last question. It's much more specific. It's related to the letter that you sent to Congressman Jason Smith with respect to the impact of the reconciliation package on coverage. And one of the estimates from CBO is that about 2.8 million people would lose employer-sponsored insurance. And we have been having a dialogue with the Senate Finance Committee majority over the implications of that, why that happens. And can you just kind of dissect that a little bit? Because one of the policies that we're very concerned with, we have a lot of employer groups in our coalition, is the elimination of the employer firewall and how that might disaggregate the employer risk pool and the impact that might have on their ability to continue to afford coverage.
Yeah, I know it's an important question. And again, obviously CBO is not going to say to policymakers, you should or should not, retain or not retain the firewall. We have to be ready with the analysis of what would it mean for employer-sponsored insurance, as that happens. And as the letter to the ranking member, Jason Smith from Missouri is the ranking member in the Budget Committee, those were important considerations in our analysis of the provisions. And this is the shifting around of insurance coverage, right? The net increase in insurance coverage, as you pointed out, was less than the gross, just because there are people who shifted from employer coverage to subsidized coverage through other ways. Of course, employer coverage has a subsidy as well through the tax system. We're doing a lot of work to analyze what will happen to the employer system in various situations. Again, I mentioned before, as the subsidies get longer in duration and more expansive. I wish we were in person. I'm trying to use my hands here, but it works a little bit maybe on the screen, but not as well. If we're in person, it'd be better. So that's one. And what does it mean for employers? What does it mean for uptake? And then if the firewall is changed or removed, what would that mean for employers as well? And that's going to be an important consideration. And of course, policymakers are focused on expansions of coverage, but within the expansion, right, there will be these kind of, the offsetting flows, and that's what the letter does. So, I, as a long way of saying, I don't have the answer, but we are thinking about it and what that would mean, and we'll be prepared to explain that to policymakers who naturally are interested in what does any policy change do to the ESI system.
Yeah. But it's reasonable to assume that full 2.8 isn't 100% the result of the employer firewall. There's different dynamics within that 2.8.
Yeah, I think that's right.
Great. Director Swagel, we really appreciate you being here today, and your insights are interesting. There's so much of CBO. I was 12 years on the Hill. Sometimes you live and die by the CBO sword or the estimate. And so you've got a tough job, and I appreciate you calling the strikes down the middle and for your time and attention to this conference today. Really appreciate it.
Thank you so much, and look forward, hopefully do it in person in the future.
Absolutely. Thank you.
Yeah, wonderful. Thank you.
All right. So now we're going to switch over to our panel discussion informed by what Director Swagel said, and moderated by Andrew Barnhill with IQVIA. Andrew, take it away.
Thank you so much, Joel, and thank you, Director Swagel, for that. Great queuing us up today for our discussion. I'm Andrew Barnhill, and it's a pleasure to host today's panel discussion. I have the privilege of leading public policy and government affairs for IQVIA, which is the world's largest clinical research and human data organization. And I also have the distinct privilege of serving on the policy faculty of NYU's Wagner School. Now, while I come from the manufacturer and clinical research side of the healthcare landscape, today we're very fortunate to really have a wide range of views represented. I'm particularly excited about today's discussion because we often only hear independently from stakeholders across the healthcare ecosystem. But today we have the opportunity to assemble a collection of executives and policy leaders from the companies and organizations that are really driving the healthcare delivery debates in the United States. And among them, the Federation of American Hospitals, the National Association of Manufacturers, the Blue Cross Blue Shield Association, and Teladoc. So before we get started, I'd love to have each one of those panelists introduce themselves and tell us very briefly who they represent before we kick off our discussion. We'll start with Justine.
Thanks, Andrew. Great to be here. I'm Justine Handelman, Senior Vice President of the Office of Policy and Representation for the Blue Cross Blue Shield Association. We are a national federation of the 35 independent Blue Cross Blue Shield plans that provide coverage in every zip code and every market across the United States and Puerto Rico. So pleasure to be here with everyone today.
Thanks so much, Robin.
Thanks, Andrew. Nice to see you and everyone on the panel. As Andrew noted, I am with the National Association of Manufacturers. I lead on infrastructure, innovation, and human resources policy. That is a mouthful, but for the purposes of the pandemic, I've been really involved in workplace health and safety issues, always healthcare, and working on vaccine acceptance among the manufacturing workforce.
Excellent. Dr. Shah.
Good afternoon or good morning, depending on your time zone. I'm Bimal Shah. I'm the Chief Medical Officer at Teladoc Health, overseeing our product strategy, analytics, and quality. We're the largest global provider of virtual care based here in the US, and looking forward to the conversation. Thanks for having us.
Great. And finally, Don.
Hi, thanks. And thanks for having me here today. Don May with the Federation of American Hospitals. The Federation represents the tax-paying hospitals in the country, and we represent large systems that are across the country providing inpatient, outpatient, and post-acute care. I am Senior Vice President for Policy and work in our policy group on Medicare and health system delivery policy. Thanks for having me.
Thanks so much, Don, and thanks to all of our panelists for joining today. So today we want to ask a variety of questions about pricing and affordability, all within the context of the proposals that could impact future healthcare costs in the United States. And so I'd like to begin by diving into maybe the lessons learned from COVID-19 thus far. How has the pandemic launched different or renewed conversations about the cost of care? And I'd like to open that up to any of our panelists.
I'm happy to get us started. I think first of all, what the pandemic sort of first forced on us was, I think, shedding a spotlight on a couple of real key things, right? So around access to care, inequities in care, and even thrusting into the conversation the modality of care. And as we are still making our way through this pandemic, I think there's been some clarity as we went from less than 1% of sort of all healthcare visits being virtual or enabled by telemedicine to over 80% at one point in time. That quickly we found that patients enjoyed the access, right, and were empowered by that, and providers were also came to the realization that this was a mechanism to help them be efficient with interacting with patients in a very different format that really decoupled them in terms of thinking about brick and mortar infrastructure to support that. And so one of the things that we've seen as time has evolved over the last 20 months of the conversations around cost of care is really how do you think about enabling visits that are in a different side of care that can be enabled in a lower price point than your traditional in-person visits. And so that conversation is really exciting because now it's really altering the conversation. Is telemedicine important? Is there value for patients or for providers? And really shifting to say, what's the right mechanism for payment? Because there is value in thinking about an alternative side of payment that has a cost arbitrage to it, certainly, because you don't have to have physical infrastructure. And sometimes the full staffing that you would need to manage one of those on-site healthcare facilities. So that dialogue still is evolving, but I think there's clear trends and excitement on all parties to sort of think about how to define that care paradigm in a different cost envelope and business model.
And I might just piggyback on that too. We certainly in the payer, Blue Cross Blue Shield, saw a huge uptake and increase in the use of telehealth and e-visits, and certainly some learnings as we're going through. There are certain conditions and specialties that lend more to telehealth, and we're certainly seeing that on the mental and behavioral health side as well. Acute visits, there are things, but at the same time, there are times when you need to see a doctor, and making sure that we're balancing that people can access the care they need, safely from their home or wherever they may be, but making sure we're not duplicating services where we're doing a telehealth visit. For example, experience happened to me where you may feel something and have normality where the doctor actually has to put hands on to say, is this something that I need to follow up on? So you don't want to duplicate where costs could go up. The other thing we've seen in the pandemic, and I think Dr. Shaw, you mentioned the inequities. It really did lay bare the inequities that exist in our system, and the inequities not only the impact disproportionately on people of color, but also in rural areas, and a real need to make sure we address those inequities, because it can drive costs when people, aren't getting the care they need, the prevention early that could lead to worsening conditions or worse outcomes. And then the last thing I'd say for now is we did see a significant decline early on in care. More than we know that 1 in 3 Americans actually delayed or skipped medical care during the COVID crisis, and more than 3/4 of them had an underlying chronic condition. So what we're seeing now in the data is that people who delayed or missed care may have worse outcomes, something that might have been caught early, maybe later, and again, can drive the cost. And I really think we're going into a new world as we move forward coming out of the pandemic, of how you can bring technologies in to help assist care, and also how we pay. We know that providers and that were in value-based arrangements, global budgets, total cost of care, fared much better than those that rely on fee for service, and how we can continue to move in that direction, especially with primary care at the center to quarterback, we think could really see some significant improvements and more efficiencies in the system, better outcomes.
Thank you, Justine. Now, you've both mentioned health equity as certainly an important factor in our discussions about healthcare cost. Could you all speak to the interplay between social determinants of health and cost of care? And I'd love to open that up to Robin or Don, perhaps.
Yeah, well, I can jump in, and I do think we really did see, as Justine mentioned, and you've highlighted, this real evidence of the disparities that have probably been there. And I think one of the things that we saw was that there was an access issue, and that whether that's because of where you live, being rural or in an inner city community, or just your ability to have insurance and to feel comfortable being able to go to a provider, whether that be a hospital or a physician. We saw real changes, real evidence that people of color and other categories in living in rural areas, their care wasn't as good. They had lower or higher mortality. And we can see that this plays out probably in all of healthcare. When you don't have insurance, as I think everybody knows, you're not going to get care. So you're coming to the hospital late. And as Justine said, we're starting to see the data in our hospital data as well, like the health plans, that while our numbers are going down now that Delta has dropped and is not driving emissions as much, our discharges are going down, but the patients that are coming are staying longer, they're sicker, and it's for conditions that probably would have been able to be treated at lower cost and with better outcomes had they been able to get the care when they needed it.
Excellent.
I'll chime in just to sort of add to the dialogue, just for awareness. 99% of manufacturers offer health insurance to their employees. So there really is a strong commitment to taking care of people and their families within the manufacturing sector. I think the pandemic vaulted manufacturers into a leadership role when it comes to healthcare because of the vaccine hesitancy and the work that plant managers, people who have never really had to intersect with their employees on key healthcare decisions, to really be advocates for a public health issue that they themselves didn't know a whole lot about, but had to learn and really become, I'll say, experts, along the way, and having conversations with people to make them comfortable with working safely in the workplace, and what is COVID and how is it transmitted. And then when we came to the vaccine earlier in the year, and why this is the way to get ourselves out of the pandemic. And so it really has opened up a lot of different opportunities for important conversations, not ones that necessarily people were trained for, but had to really get up to speed. And it's going to be interesting to kind of see how this will evolve over time. And certainly manufacturers' commitment to providing quality healthcare has not ceased. It's still very strong. But it was a learning lesson for sure, especially in dealing with views about the pandemic or about the vaccine.
Let's talk about workforce for a moment. Workforce issues have arisen in our pandemic world and need to be addressed as we discuss challenges related to cost. Robin, we can actually probably stay starting with you. Can you speak to what you're hearing from employers about some of the rising workforce challenges?
I mean, this is, I think every sector is facing some of the biggest shifts in workforce right now, just because of, I think they're terming it the Great Resignation, and that many, folks who are of the boomer age are actually retiring, and this wave is occurring. The manufacturing workforce is generally older and even less healthier than the general population. So this is going to be a fascinating shift. We have close to 500,000 unfilled jobs in manufacturing. It's going to obviously grow and be much more severe. And so we've had to tailor our outreach to specific communities, to specific students, really working hard to talk about the importance of manufacturing, not just as a sector, but really the career opportunities, and what does a career horizon look like in manufacturing, and make it accessible to young people. And so we right now have a road show called Creators Wanted, and it's traveling around the country, and through a truck experience, students get on board. It's all safe. They wear masks and socially distance, but we've had to really work hard to demonstrate that manufacturing is alive and well in the United States, and that there is a career opportunity for folks.
Thank you, Robin. I'd love to hear from the others about your perceptions of some of the workforce challenges as they relate to cost.
I can start. I think, one of the things that we saw during the pandemic was that healthcare providers showed up. They were there, and they were the heroes early on in the pandemic, and I think continuously through the pandemic, because they were the ones who, they were quarantining from their families and doing everything they could, especially in the early days when we didn't know a lot about transmission. Took a lot of risks. And, I don't know if you saw or not, but I actually saw in Halloween, you had costumes for nurses and doctors who were doing this. So it was really great. So I think that this renewed appreciation of the healthcare workforce really came through. I think one of the things that we've seen, though, is that the pandemic has really shown the workforce shortage that we have in healthcare. We already knew there was a nursing workforce shortage that has really been laid bare in the summer and the fall, as we move in to a place where we see major shifts in our workforce, whether that is retiring nurses or increased demand or just tired. The cost of traveling nurses has gone up tremendously. And those are the nurses you bring in when you have drops in employment or changes, whether it's baby boom, as Robin said, or just being tired. We've seen the cost go from, less than 100 for a traveling nurse to 150, 175, $200 an hour for nurses. So when you talk about costs and you talk about a workforce shortage in healthcare, labor is 60% of a hospital's cost in a lot of cases. And if that is going up at the rates that we're seeing, I think we are starting to be concerned about what that is going to do to the cost of healthcare. But we need those nurses at the bedside. So for us, I think that's going to be a big issue. It's a solution. We've got to find some solutions. It's a problem we need to find solutions for. We need to be able to find ways to attract people into this field because while this is definitely a challenge right now during COVID, where we've got burnout, we've got a long-term problem that we need to address as well.
Thank you, Don. And Justine, did you want to jump in?
Yeah, and one thing, and maybe just taking workforce too in a little bit of the direction, I agree. We do have shortages, and we're going to need to make sure we've got the appropriate workforce to treat people. But it's also, we've done a lot of work in the Blue Cross Blue Shield system plans across the country of how we've worked with provider practices to really set them up in ways where I call it practice at the top of your license. So for example, making sure you've got in a primary care office, a mix of nurse practitioners and physician assistants that can be there to help, deal with many of the things that need to be dealt with, but that the physician is utilizing their time if they're managing multiple chronic conditions. Certainly, as we see with technology, the appropriate use of telehealth, but making sure that we're setting up those practices and how we have our payment incentives to really encourage that, because then you're getting efficient, high quality care, and you're allowing the medical doctors to really be focusing on managing those chronic conditions. And also in the health plan world, how we tap in using our case managers and connecting those dots. Certainly we want to make sure we're keeping people out of the ERs when they don't need to be there, because that's more expensive care, and building those relationships between patients and their primary care doctor, who can really be the quarterback. And if they've got that practice set up to meet their needs so that they don't need to go to an ER if something comes up, really a way to make sure people get better care, better outcomes, lower costs.
Thank you. So we touched on telehealth as we discussed the broader landscape shifting under COVID-19, but I'd like to dive in a little bit more to that discussion now, to think about how has the increase and proliferation of telehealth impacted the cost question. And I'd love to turn that over to Dr. Shah, but open it up to others as well.
Yeah, I mean, I think, certainly in the short term, there was payment parity that was granted for, during the public health emergency between, traditional in-person visits and telehealth. And that was important in the wake of everything that was going on. We think long-term, payment parity is probably not the right way to go for Insight versus virtual care, because we know that there is a cost differential, right? Two, I think, that can help address some of promoting access, but making sure that it recognizes the site of care as being more efficient in a number of ways. The second is recognizing with increased access as well, that we're able to provide that accessibility, provide that care to help prevent future problems as they arise. And so as we think about the cost of care in virtual care, obviously there's that immediate sort of transactional opportunity to provide care. We also need to look at, as we provide more preventive services in that modality, what that downstream impact is. And then, finally, thinking about different payment models, because certainly virtual care is just not about connecting via video or phone. There's, certainly those synchronous aspects, but there's asynchronous aspects of someone sending me an email or information about, their blood pressure after I had a, in-person interaction with them. And how do you think about, evolving out of a pure fee-for-service model into one that really accounts for taking care of that individual across a longer period of time, to account for those interactions that drive access, that drive value into the system, but aren't transactional in their fee structure.
Great.
I'll chime in because it was a very popular service during the pandemic for the manufacturing workforce. I think telehealth services doubled for many of our member companies, and some feedback has been, this has been great. I'm surprised we haven't done this sooner. But also at the same time, everyone at the end of the day will want to know about how this will improve costs, because that's where manufacturers certainly are focused on curtailing some of their healthcare costs in order to be competitive, because when they're putting money into healthcare, they're not putting money necessarily into modernizing some of their equipment, expanding facilities. It sort of comes at the cost of other areas of investment. So that's why manufacturers really get focused on costs and efficiencies. They're people that measure everything they do because of the line of their work. And so when they look at healthcare, they want to reduce waste. And so I think telehealth is definitely a great benefit. And so long as the cost equations get worked out appropriately, I think it will be certainly a growing service. Another thing manufacturers have started to do years ago is offer more on-site, near-site care options. And I think that was an added benefit for manufacturers during the pandemic, as well as in support of some mass vaccination campaigns for the workforce.
Thanks, Robin. So earlier in the session this afternoon, the CBO director reviewed some of the latest trends regarding cost of care. Is there anything that you would perhaps add from your specific parts of the healthcare ecosystem that you feel could have been elaborated on from that report today?
I'm happy to jump in. I know the director talked about provider consolidation, and certainly that's something we've seen in the pandemic, especially smaller independent physician practices, which may be consolidating with bigger practices. We've also seen a trend with private equity firms buying physician practices and other provider areas. And certainly we see that when that happens, it drives up costs. All states have network adequacy requirements for health plans. And if you have a dominant provider in an area that controls the market, they can really push for higher prices, and it gets passed on to premiums. I mean, premiums are set based on the cost of goods and services. We've also seen tremendous increases in drug prices year over year, and drugs that, pay for delays and other things that extend patents well beyond the term that they were originally set for. And we at Blue Cross Blue Shield were invested in Civica RX along with 18 of our plans to bring generics to the market quicker, starting in 2022, and do it at cost to provide more competition. But you've got prescription drugs now that make up more than 20% of premiums, and it's growing year after year. So really something that needs to be looked at. I think as we look at some of the two of the biggest factors right now are really the consolidation that's driving up prices, along with prescription drug prices are driving up premiums.
And Andrew,
Yeah,
from my perspective, not that we have the answers today, but something that was highlighted is just like, really understanding what the cost over the long term of foregone care is going to be. I think there is, pretty clear that we know that obviously health disparities widen, but we also know that people with chronic conditions, a lot of their health status indicators increased. We know that mortality the average age of mortality in this country dropped for the first time in light of a lot of things going on with the pandemic, not just related to COVID-19, but with these uncontrolled risk factors. And so I think as the CBO, continues to examine this, really understanding, not only what the impact has been in 2020 and 2021, but what is it going to look like over the next 3 to 5 years? As I think we heard from somebody earlier, 1 in 3 Americans, foregone care, more than half of those had chronic conditions, and we know that there's going to be a downstream impact because of that.
Great, thanks for sharing that.
Yeah, and I would just weigh in there as well. I think Dr. Shaw said it, and we saw a lot of that presentation being about coverage and about access. And one of the things we need to do to address the long-term cost solution is to be able to make sure people can access the care when they need it, so they're getting it the most efficient time possible. And so, I think that access issue is going to be a key concern. And while there will be some spending there, because all of a sudden people will have insurance, they will be getting the care when they need it, and long-term it will lower costs. I think the other thing is, and Justine brought up consolidation, and I do think consolidation needs to be looked at because all consolidation isn't the same. And there is a lot of consolidation. If you look at health systems, one of the things we saw during the pandemic was that it was health systems that could respond, that were able to provide learning organizations and to be able to share learning from one area that was going through the pandemic. Hospitals in one state, for example, in New Jersey, during the early wave of the pandemic, those hospitals were able to share information to their system hospitals throughout the country. I'm thinking of Ardent or HCA, where they could take that learning, apply it to other places, and lower the cost of providing care to those COVID patients, and also improve the outcomes, even though they hadn't experienced a surge yet. So systems can also bring a lot of cost savings, and integration can bring cost savings. We've seen that time and time again. And I think, so as we think about consolidation, we need to think about the right ways of addressing consolidation and recognizing that there are tremendous benefits there as well.
Great, thank you, Don. I now want to shift our conversation slightly to Capitol Hill directly. We've seen recently the resurgence of an old debate about government price setting for therapeutics and services. So thinking about some of the new proposals that are out there that may be new of old proposals, if you will, should we expect legislation and perhaps legislation or regulation to impact future healthcare costs in different ways? Or is the latest debate on Capitol Hill really just the continuation of ongoing pricing pressures for the industry, and particularly for manufacturers?
I can jump in. I think, part of the debate, and one thing I'd say, I know, just back to Don's point earlier about access, I think we're at a point where we've got a door to get everyone covered through our existing system, whether it be through the ACA, through an employer, through Medicare, through Medicaid. I know the proposal on the table before Congress right now would close the Medicaid coverage gap in I think it's the 12 states that haven't, which is critically important. And once we've closed that coverage gap, we've got a door to get everyone covered. But the real issue is the cost of care. That's what drives premiums. And we know as a tool to make premiums more affordable, people sometimes gravitate towards high deductible health plans as a way to keep their premiums. But you can't have, if you can't afford the care, that's a problem. And so I think there needs to be a real look at what is driving healthcare costs and what solutions are out there. I mentioned, Blue Cross Blue Shield's invested in a nonprofit drug manufacturer to bring generics to the market cheaper. But when you've got prescription drugs driving upwards of 20% or more of premiums, there's something that needs to be done to make sure that there's competition and affordability there. I think things like a public option that's been talked about, we don't need that for access. That basically is trying to solve for affordability by setting, at rates of Medicare or some percent thereof. And really where we need to move is to more value-based arrangements, total cost of care. We have to find solutions to lower drug costs, but at the same time, we want to make sure that there is effective public-private partnerships on the system that we have today. So I can't predict what's going to happen. It's been a crazy 24 hours, I'd say, even.
And I will jump in to emphasize, we are at Wednesday afternoon. For those watching the recording, there may be changes within the next 24 hours if you happen to listen to this webinar after the fact. But currently, we're seeing negotiations continue, particularly for Senate Democrats. Yeah.
I'll chime in here if that's okay. And I do think we have to make sure we don't damage what's working or create an additional set of harms here, in the sense that the employer-sponsored system is working very well. It's been very successful. And we don't want to create a scenario where suddenly it becomes attractive for some individuals to go off into the public realm, so to speak, for health coverage, whether it be an ACA exchange or, Medicaid, and or Medicare buy-in as another example. I think that employers really, I think, work very hard to provide quality benefits to their employees, and I can speak for the manufacturing sector, and have worked to introduce innovations in the delivery of care. I think there's a lot of innovation going on sort of within healthcare offerings, and they want to do better at it too, and they need increased transparency. They would love to be able to have economies of scale for certain aspects of services and coverage that they provide. Certainly cost is a driver and a great concern, but I don't think direct government interventions are sort of the right answer here.
And Robin, to follow up on that, why do you think that so much attention right now on the congressional front is focused on one small sliver of cost with prescription drugs?
Because I think it's about a win at the end of the day. And I think that it is a politically charged environment, and there is a desire for a big win here and to take a victory lap. But I think it will cause more harm than good. I think we should be worried about innovation in this country. We do have, I would say, an amazing drug discovery process and an ecosystem here, coupled with a strong manufacturing base, and we should not harm that.
Great, thank you, Robin.
And maybe just one point on that. You know, I think part of the reason too prescription drugs is being looked at is it's just the rate of increase year over year has been significant. And certainly we don't want to see innovation go away, but I think greater transparency into the pipeline of drug development, where it starts and where it finishes. The government does put a lot of money into research and development, and it's not always clear where that goes. So I think that's a focus. You know, certainly I think everyone's looking for a win, but you know, looking for something that's going to make healthcare more affordable for everyone.
So I would like to close with one last question on my end, and then we can see if any of our attendees have questions that they would like to raise in the chat box that we can devote a few minutes to as well. And so my final question is sort of bringing this discussion together today. Are there any solutions for improving affordability of care that we might have missed, either in our conversation today or in previous conversations that you've noticed have taken place, particularly on Capitol Hill and inside DC, that maybe are worth our attention, but haven't been receiving it so far?
I can start. I think, and Justine touched on this briefly just a moment ago, and that is really looking at new delivery models and value-based care options as a way of thinking about not just addressing cost, but really changing the way we deliver care. And the one additional nuance there is, I would say, what the pandemic in part has shown us is that technology can be used in a new way. And so whether that's integration of telehealth in a more effective way, or even, you know, hospital at home, telemonitoring, there are going to be different models that are going to require a public and a private partnership where we can look at these new value-based models that really drive to outcomes that improve quality and care delivery, that I think are really kind of the future direction of addressing it, because we just can't say we're going to just cut the price as a way of doing something. It really has to be, how do we make sure we're driving toward value?
Any others that wish to weigh in? Yes, Dr. Shaw.
Yeah, I was going to agree with Don completely. I mean, I think we need to be flexible on a go-forward basis of how we think about sort of all the different ways that people will need to get care and want to get care, and think about new care paradigms, new payment models that align, you know, certainly, you know, accessibility with reducing disparities, with improved health, with a different cost structure. I couldn't agree more in terms of, you know, I think it's an exciting time to start thinking about these things, because what the pandemic has done is unleashed a significant amount of innovation, and now it's time to you know, see what sticks and what really drives value on a go-forward basis.
Yeah,
Right.
I'd agree. There's opportunity, especially coming out of the pandemic, to move into more value-based, total cost of care arrangements. And certainly accelerating out of CMMI, what they're doing across government programs is important. And I also think investments for the Federal Trade Commission to make sure that they've got the resources they need to really be looking at all healthcare markets to make sure that there's adequate competition, and when there is mergers and acquisitions, to make sure that it's not going to take competition away or drive prices up is another area.
Great, thank you. So we did have one question come in so far, and I'll keep it open to see if there are any others. And this individual is asking, where in your fields or particular parts of the healthcare ecosystem can we find efficiencies to lower the cost, be that through innovation, legislation, or regulatory changes? So something specific to your part of the healthcare system.
Well, I'd say for health plans, I think people sometimes forget, but health plans essentially have a profit cap, if you will. It's called the medical loss ratio, that if we don't spend the vast majority of premiums on care, we have to rebate it to the consumer. So, that's really made sure to drive down administrative costs so that you can really focus in. Again, I would go to where we've seen tremendous progress is around patient-centered care models, really where you have a primary care doctor that is serving as the quarterback, if you will, and making sure that their patient's getting the right care at the right time in the right setting, avoiding the ER, going to the right specialist when they need to see them, and taking care of their needs along the way so that conditions don't become chronic or escalate to become, worse. So I really think that investment in primary care and making sure that, again, where you're giving that primary care the freedom in a total cost of care situation to be able to best manage that patient for the best outcomes is a great investment where you're seeing efficiencies and lower costs.
Great.
Yeah, and I'll add, leveraging other care providers across the care continuum, right? Making sure that people are operating at the top of their license to really maximize the efficiencies that you can get with, advanced practice providers, coaches, social workers, and really meeting the individual's needs where they are. Because sometimes, a lot of times, what the individual doesn't need is a physician, and that this is coming from a physician. So understanding that need and being able to enable, people to operate at the top of their license to deliver high quality care at, an affordable price points could be really key moving forward.
And if I can I'll just throw in one option. I know we're running a long time, but I think the other thing that we're starting to be able to take advantage of is data on actual clinical care in a way we couldn't before. And, we've spent the last 10 years trying to develop and build electronic health records. We're now finally, I think, getting to a place where we can use those in a real-time way to really change care. And I think that's something that we've seen just over the last couple, 3-4 years at the max, where we're really starting to leverage that ability. We saw it play out in the pandemic. And I think the real opportunity point we have for us moving forward, and whether you call it AI or, just learning organizations, but this ability to use the clinical information we have in a real time to change care delivery, change care decisions, and not just improve quality, but also lower costs.
I'll add too that a long-term mindset is really important in this space. And I think too often our political leaders might look at some short-term gains here, but I look at the manufacturing sector in particular, and they've done some very interesting things, and some member companies specifically, who have just taken on PBM responsibilities themselves. And it was really daunting at first. And at the end of the day, they found a model that worked for them, and over the 15-year horizon, they ended up saving a lot of money by taking on a role and responsibility they were unwilling to do at first, but saw that there was a benefit at the end of the day. And I think, again, speaking to the need for transparency and really, being able to dig in and understand the cost drivers of the system is so important for our members.
Well, thank you so much, Robin. And thank you to each of our panelists for joining today and all of the attendees who were able to participate in this really vital discussion. I think we heard a variety of perspectives from some of the key individuals and key organizations that are driving the discussions about health cost forward here in Washington and here broadly in the United States. So thank you for joining. On behalf of the Council for Affordable Coverage, we thank you all for participating, and we encourage you to tune in to the next session in the Price of Good Health Summit, which will occur on Wednesday, November 10th, and we'll discuss coverage and access. Thanks again to the partners at Pharma and the Blue Cross Blue Shield Association. We appreciate your joining us today. Have a great afternoon.